Yeah, we can start in 3, 2, 1. Please go ahead.
Very good evening to all of you. On today, the 26th of January, it has been a while since we had an academic session, but I think this was just about the right time. We had to hastily convene this session, but then I think the situation demanded it. Thank you all for joining. I hand over to AMBUJAM Madam for the introductory remarks. AMBUJAM Madam is the immediate past president of the Kerala Federation of Obstetrics and Gynecology and consultant at Rajagiri Hospitals now. AMBUJAM Madam, over to you.
Venu, respected President Kfog, Dr. AJITH, Secretary Dr. Venu, the experts of the day, PAILY sir. Very good evening and welcome to this evening program of Kfog, COVID-19, riding the current wave. The caption, ideal, I think might be Venu's suggestion. Anyway, it's a need of the hour. This is going to be an interactive session moderated by PAILY sir, Dr. BETSY, involving the experts in this area, Dr. AJITH, Dr. ARAVIND, Dr. JAICOB, and Dr. SANGEETHA. Now, yes, we are going through the third wave of the pandemic, and our concern is more and more pregnant women are getting infected. And we know that the second wave was catastrophic, claiming so many lives, and we have not come out of it. With much pressure, we could introduce vaccination of the pregnant and lactating women across the state, but it is found that still there is some reluctance on the part of the women to receive the vaccine. Now, the current issue is WHO has already expressed the concern over the rising COVID-19 cases with a new variant, the Omicron. This variant seems to be highly contagious, spreading very fast, very easily. But there is a silver lining, of course, because it is causing mild infection, limiting to the upper respiratory tract. And most of the women we find till now are not going to the category C. But we don't know what is the infecting agent, whether it is the Delta, whether it is the variant. And there are a lot of queries regarding whether to look for these variants by genome sequencing, which is not very easily available. Whether there is a need to modify our treatment protocols. What about the role of antibody cocktail? How to modify the obstetric management? And the dilemma of managing a woman who is nearing the expected date, and so on. We have many, many queries, and it is now time to update ourselves. And today we have with us all the experts to talk about this. And I think we'll use this opportunity to update ourselves on the current perspectives and management protocols. Let me wind up. Thank you very much. And over to you, Dr. Venu.
Thank you very much, AMBUJAM Madam. I shall just run you through today's program. That at first we have a talk by our President AJITH sir on COVID-19 and pregnancy, the current perspectives, which is followed by we propose it to be a very interactive session. It's a frequently asked questions in day-to-day practice. To moderate that will be PAILY sir and Dr. BETSY, and we have experts here, Dr. ARAVIND, Dr. JAICOB, and Dr. SANGEETHA. So I request all of you in the audience here to make use of the facilities, the chat box and the Q&A box there, so that you can put your questions there, and I'm sure our moderators will pick up those questions. So do use today's session to enrich yourself academically and have this session help in your day-to-day practice. We shall go ahead to the first talk of the session. Today, AJITH sir, our president and the person behind this meeting, it was his one phone call which made us hastily arrange this particular meeting because he felt that it was the felt need of the hour. Sir is our president. AJITH sir will talk about COVID-19 and pregnancy current perspectives. Over to you, AJITH sir.
Thank you, Venu. Let me share my screen. For me, there is some issue with power supply, but still I will continue. I hope you can see the slides.
Yes,
okay. Today, what my plan is to give some introduction, because you all know how to manage COVID-19 pregnancy. We are with COVID-19 for the last 2 years. But this third wave, is it different from the other? So some important points and the questions we will discuss at the end. This is the trend that is as of yesterday from Kannur. The prediction is in Kannur district to peak by February 13th. So February 13th, the expected number of caseload is 41,000. And by February mid, it will fall. And it will flatten by first week of April. I think we can extrapolate it to the whole of Kerala. So almost the same thing you can expect. So the number of cases will be more. So that is the expectation. The most common symptom is most of the patients are asymptomatic. Most common symptoms are cough and fever. We all know that pregnant women are not at increased risk of infection, but once they're infected, especially in the third trimester, there is more chance of getting severe illness. Again, from the experience from the second wave, we know that the Delta variant is more severe. The need of ICU admission is more compared to the Alpha variant. But coming to the Omicron, even though it's a less severe infection, it's more infectious. Definitely, we can expect some adverse outcome, both for the mother and baby in unvaccinated pregnant women. The risk factors for getting infection and getting serious illness are age more than 35 years, obesity, pre-pregnancy comorbidities like diabetes, hypertension, healthcare workers, and those in other public-facing occupations, low socioeconomic status. We have the Kfog the guideline that is published in the May 1st of last year. Again, almost the same, the categorization, the clinical severity, all this the same classification. Category B1 is asymptomatic, category B2 is symptomatic, or those with comorbidities like hypertension, gestational diabetes, or diabetes. When they have breathlessness or reflex symptoms, definitely goes to the category C. Again, the classification, mild, moderate, severe. When the respiratory rate is less than 24, SpO2 more than 94, otherwise it's symptomatic, it's mild. When the respiratory rate is between 24 and 29, SpO2 91 to 94, and when there is fever and cough, it is moderate. Respiratory rate more than 30, SpO2 less than 90, pulse rate more than 120, or those with pneumonia, it's a severe. What are the effects of COVID on pregnancy? Definitely, from the past 2 years experience, we know that there is no increased risk of miscarriage. There is no increased risk of congenital anomalies. The vertical transmission is possible, but fortunately, there is no much adverse effect on the babies, even though they became positive in some cases. Definitely, there is a risk of preterm delivery, about 3 times risk of preterm delivery. And it is not spontaneous preterm delivery. Most of the cases are iatrogenic. Because of the COVID, we have to deliver the baby early. FGR is another problem, about 2 times more risk. So definitely all patients getting infection and continuing the pregnancy, we need to do ultrasound 2 weeks after positive result. The risk of stillbirth is increased 2 times. So careful monitoring of pregnancy is very important. Perinatal mental health disorders are more common, not only in COVID patients, even in the pandemic, all pregnant ladies, there is a high chance of getting perinatal mental health disorders. So the treatment again, as per the care for the GCPR that is published on May 1st of 2021. Category B1, self-isolation at home can be recommended if it is not near time. Obstetric care should be routine. So we should not deny the obstetric care just because she is a COVID positive. So if she has to come to the hospital, we have to give the do the examination, and we can definitely send the patient home. Self-isolation can be done. Avoid complete bed rest. Adequate hydration has to be advised, and our patient should be advised ambulation because there is a risk of venous thromboembolism. Better, she should procure a pulse oximeter. And if there is a fall in SpO2 below 94, she has to contact the doctor and go to the health facility. Another thing is very important thing is 6-minute walk test. Even though in pregnancy it may be difficult, but still it's a very good test where she has to walk for 6 minutes. If there is a fall in the SpO2 by 3%, that means it's positive. She has to go to the health facility. SpO2 less than 94 or walk test positive needs to go to the hospital. And this patient should be advised ultrasound 2 weeks after positive result because there is a possibility of FGR and 2 times increased risk of stillbirth. Again, these are the recommendations that is again given in our DCPR. Category B2 patients, that is symptomatic patients, they may need hospital admission or admission in the CSLTC. Careful monitoring of SpO2 is very important. Respiratory symptoms are, if the respiratory symptoms are present, just like we cannot roll out H1N1, so we have to start oseltamivir, otherwise it's not needed. Lab investigations, test X-ray, all these things that is recommended in our GCPR has to be followed. May plan discharge if symptoms subside. If it is category C, multidisciplinary care in designated hospital. So these are the lab investigations that we again discussed in the GCPR. At admission, CBC, RFT, LFT, CRP, RBS, serum electrolytes, and if there is tachycardia, ECG. If there is a clinical indication, definitely we should not defer chest X-ray or CT just because of risk of radiation exposure. We need to do it early. D-dimer, ferritin, LDH, and if there is any suspicion of infection, any rise in the TC, total count, consider doing procalcitonin and blood culture. D-dimer values again is trimester specific. May not be the same value that is applicable in the non-pregnant, may not be applicable. So in the first trimester, if it is more than 1.2, it is high. The second trimester, more than 3.2. In the third trimester, more than 3.3. We have to consider it as high value. If clinically deteriorating, investigations has to be repeated every 48 hours, depending upon the case. And we need to screen for opportunistic infections if she is immunocompromised, like HIV patients. So one of the important part in the management of COVID is prevention of venous thromboembolism, because COVID-19 is there is a possibility of getting venous thromboembolism. And another thing is pregnancy is a hypercoagulable state. So together there's a chance of getting even though we say that our people are less prone for venous thromboembolism. Actually, if you go through the cases and all, especially postpartum patients, DVT and pulmonary embolism are possibilities. So we need to give prophylactic low molecular weight heparin to all admitted patients, especially near term and postpartum patients, unless birth is expected within 12 hours. And we have to increase the dose, higher dose in severe cases, especially category C, and when there is other risk factors, and it has to be continued for 10 days after discharge. And if there is a risk continuing, we need to give it for a longer period. So this is a very important investigation. We have to try and prevent, and if developed, treat it properly. And we have to think of possibility of pulmonary embolism, especially in patients with chest pain and worsening hypoxia. And in women whose breathlessness persists or worsens after the expected recovery from COVID-19. What about steroid? Which patients we have to give steroids? Moderate to severe rise in respiratory rate or fall in SpO2, even without pneumonia. 3% desaturation with 6-minute walk test. Bronchopneumonia, and there is marked rise in the pro-inflammatory markers with symptoms. So these are the indications for starting steroids. as Dr. ARAVIND says, the steroid in the right time, right dose, in right patient, definitely saves the patient, but should not be abused. And what steroid? Usually we start with injection dexamethasone, especially if we are interested in the lung maturity also. But in the first trimester or in the towards time, it may not be necessary to start with dexamethasone. 4 doses. After that, we continue with the injection mediated prednisolone, 0.5 milligram to 1 milligram per kilogram body weight, or usually 40 milligram OD. Or we can go for oral prednisolone 40 milligram OD, or IV hydrocortisone 80 milligram BD. Skip the DEXA if lung maturity is not an issue. Total 10 days or up to discharge, whichever is earlier, you have to give. Sometimes we need to give higher dose, but these patients, we have to monitor the sugars very carefully. If there is a high sugar, we have to consider giving insulin also. Ensure saturation of 94 to 98%. With any of the means like nasal cannula, face mask, injury mask, or a non-breather mask, or non-invasive positive pressure ventilator CPAP, or sometimes patients require intubation, or rarely even ECMO. One important thing is we have to monitor for the clinical deterioration. Even a mild symptomatic patients may go into moderate or severe cases. So clinical deterioration, we have to monitor it properly. As we discussed, chest X-ray and CT thorax should not be delayed because of the radiation exposure concerns. Signs of decompensation are increasing oxygen requirement, increasing respiratory rate, rapidly rising respiratory rate despite oxygen therapy, reduction in the urine output, acute kidney injury, and drowsiness, especially important. Even without other symptoms, drowsiness is a red flag sign. And these cases, the involvement of the multidisciplinary team is very important. And if we need to empty the uterus, we have to consider even early delivery also in such cases. Then another drug that is again giving some improving the outcome, especially including the survival advantage, is tocilizumab, interleukin-6 receptor antagonist. It is recommended in hospitalized patients with hypoxia and evidence of systemic inflammation, CRP above 75. This is as per the RCOG recommendation recently, that is 11th of January 2022. So it has to be given if the CRP is above 75 and if there is evidence of hypoxia, especially ICU admitted patients. Again, another controversial thing is monoclonal antibodies, especially high-risk patients, unvaccinated patients, diabetes, obese, hypertensive patients, you have to consider giving. Again, before developing a hypoxia, you have to consider giving it. But effectiveness in Omicron is doubtful. Molnupiravir, it is not recommended in pregnancy. Efficacy and safety is are the issues, so it's not recommended in pregnancy. But the remdesivir, safety in pregnancy is not established, but may be offered on compassionate basis with informed consent in category C patients. Recommended dose is 200 milligram IV day 1, followed by 100 milligram daily in 4 days. When short course for 3 days, early in disease is another option. Again, survival advantage is there with this dose early, starting remdesivir for 3 days. And when to deliver? Decision based on obstetric grounds most of the time. Sometimes for resuscitative purpose, after 26 to 28 weeks, if invasive ventilation is needed. But this decision has to be made by multidisciplinary team. And mode of delivery, again, depending on the case, we have to. But if you have to deliver the patient for resuscitative purpose, most of the time we have to go for a cesarean section. Or if there is a fetal distress or something, we have to go for a cesarean section. Otherwise, again, but worldwide, there is a high cesarean section rate in patients with COVID. There is a low threshold for doing cesarean sections for patients. About the intrapartum care, there should be a dedicated labor room. Continuous CTG in symptomatic patients is recommended. Even asymptomatic patients, the monitoring is intermittent monitoring is may be difficult, so we go for a continuous CTG even in symptomatic patients. In addition to the routine monitoring, SpO2 monitoring is also important. For the labor analgesia, the advantage of epidural is if she needs a cesarean section, can be easily converted. So epidural or any other analgesia has to be given. About the postpartum care, breastfeeding, as usual, mother should use a mask, hand washing before and after feeding. These patients should be encouraged hydration and ambulation to try and prevent deep vein thrombosis and pulmonary embolism. The recommendation is to give low molecular weight heparin for at least 10 days after delivery or cesarean section, or more days if there is any other indication. And another routine question most of we come across is, can we continue aspirin prophylaxis? Not for the COVID cases, say a patient getting aspirin in antenatal period for prevention of preeclampsia or FGR. Such cases, can we continue aspirin? So again, the recent recommendation for the ASIOG is COVID-19 can be associated with thrombocytopenia. So there's an increased chance of bleeding. Aspirin should be discontinued for the duration of infection, but after that we can restart the aspirin. So during the infection, we can stop the prophylactic aspirin. So thank you.
Thank you very much, Ajit sir. Shall we have a brief sort of comments, PAILY sir, Dr. Betsy, AMBUJAM madam?
Thank you, Venu, and thank you, Ajit. Very good overview of our present concepts. You have addressed many of the practical issues. And if I may just clarify a couple of points from you. The prediction that you did for Kannur, I would assume that that is applicable to the whole state. Am I right?
I don't know. It is the prediction I got from the Kannur district yesterday. Dr. Arvind may say something on it.
I think Ernakulam and Trivandrum might peak a bit earlier than Kannur, but
We hope
roughly,
so. We hope so.
roughly I think going by the number of cases and all, the state, as Ajit sir has said, by around the second week of February, it should peak. But I don't think that any susceptible will be left in Trivandrum by the second week of February, sir. So I think we will speak maybe by the first week of February.
That is next week.
In Trivandrum. So.
That is next week. Okay. One other point, Ajit, you said about the more chance of severe illness in the third trimester. Is that the observation generally? I would like to hear from others. In reality, we haven't found anything much severe even in the third trimester in the recent days. Am I right, Sangeetha?
Yes, sir. Not with Omicron, but with Delta, definitely.
Sure, there is no doubt about it. And we know from last week's discussion, as Arvind said, probably we are having the fading stage of the Delta and the ascending phase of the Omi. And maybe, of course, if there's Delta, no doubt. But otherwise, I think Omi doesn't make much of a worry in the third trimester. Am I right? Ajit,
Yes.
any comments?
We are also seeing that most of our patients are asymptomatic or mildly symptomatic only for this wave.
Okay.
But
the other question which has come in the chat box also repeatedly is about the anticoagulation. You said about prophylactic low molecular weight heparin to be continued for 10 days beyond. Do you think, are we all practicing? Personally, we are not very strictly following that. And would you like to insist on that, Ajit?
We are practicing it very strictly, sir, because we had some bad experience initially. So, enoxaparin for 10 days, not an issue for most of our patients. So they will take it. Even if they are discharged, they will take it from home.
Actually, in the, of course, if it's a severe case, that's a different ballgame altogether. But even in the milder cases, are you across the board you are giving, or only to those who had severe cases, category C or so?
All patients we are giving, sir. Even asymptomatic COVID positive patients, we are giving for 10 days after delivery.
Arvind, would you recommend that way?
Sir, actually, following the last week's discussion, there was one question raised the risk of thromboembolic complications with Omicron is less compared to Delta. Even though I could not find any solid evidence regarding that, but then there are certain reports saying that, from US, etc., the risk of thromboembolic complications appears to be a bit lesser for Omicron compared to Delta. So in that aspect, actually, so when we look at the RCOG, the green top guidelines and all, where they say that if the pregnancy is less than 28 weeks, you need to have more 4 or more risk factors for prophylactic anticoagulation, more than 28 weeks, 3 or more, and say if it is nearing term, say 2 or in the postpartum period, 2 or more. I think we should not be giving anticoagulation for all the patients. There are definitely risk factors apart from COVID-19. If there are other risk factors like obesity, diabetes mellitus, or eclampsia, etc., probably we are justified in continuing anticoagulation as we used to do. But in just for a COVID-19, I think that we should be a bit more, it's not about caution. I think anticoagulation may not be needed for 10 days post delivery and all. I think we can have a relook into that aspects. But as Sarah said, last week also, means in one of the hospitals, following delivery, 7 days later, patient did present with massive pulmonary thromboembolism, saturation was 75. Even though there was no history of COVID, the COVID antibody was positive and the patient was vaccinated maybe around 6 or 7 months back. So those things are also happening. But on the whole, COVID can be taken as one risk factor, but if other risk factors like say obesity, etc., are present, then probably we are justified it. COVID can be given 1 point, sir. It can be taken as a thrombophilic condition, but then other factors also should be there. So no risk factors, just COVID alone. Then I think so. After discharge, anticoagulation, etc., I think there is there is an opportunity for us to cut down on the use of anticoagulation. This is what I personally think, sir.
Okay. Thank you, ARAVIND. I think that probably we have to leave it to the discretion, but there cannot be a definite guideline on that, I should presume. And this is again another point that Ajit asked, and the question has come in the chat box as well about the oseltamivir. And ARAVIND, I would like to get your comment on that. In the beginning of the COVID wave, we were suggesting that everybody should get that also, because some study which was reported to us by the health services said that there's co-infection in 75% and all that. Later on, you only said that it is not continued like that, and so we are not routinely giving. What would be, Ajit as well as ARAVIND, what would be your suggestion? This question also has come in the chat box about the oseltamivir.
There is a recommendation from the government that all patients with respiratory infection be to give oseltamivir, not for the COVID. COVID, we know that is useless, but still.
No, not for COVID, as a co-infection.
We don't know. We are not testing for the H1N1. So H1N1 is more dangerous than our COVID. So that is the reason we give oseltamivir. But the question here is UTA we give oseltamivir. UTA we don't have to give, even if the patient is having COVID-19.
OMI actually is, as thankfully, mainly an upper respiratory rather than a lower respiratory, isn't it?
Sir, actually, it's a bit difficult to answer this question because we are not, as Ajit sir has said, we are not looking for influenza. Maybe around 2 or 3 months back, we did have a influenza cases as well. As of now, we don't know the circulation of the influenza strains in the community. So actually, the state is coming out with a surveillance for COVID-19, sir. As part of this, we did demand that the sample should be tested for influenza as well. But then I don't know whether it will materialize or not. But as Ajit sir did say, for asymptomatic or mildly symptomatic, so probably we need not use oseltamivir. But definitely, if the patient is having an acute respiratory tract infection, even in a patient who has been proven to be having COVID-19, there is no harm in giving oseltamivir because we know that Omicron is going to be mild in pregnancy. But unfortunately, if it happens to be a co-infection with influenza, there is an existing guideline which says that for all the influenza-like illness, we should be giving oseltamivir as well. And since we don't know whether co-infection is there for one category, that is with definite influenza-like illness, my personal opinion is to continue with oseltamivir, but not for this asymptomatic this COVID-19 pregnancy. It's not scientific answer, I know, sir. But then since we don't know the data about the circulation of influenza in the society, I think to be on the safer side for ILI, probably we can continue with the oseltamivir, but the practice of giving azithromycin and cefotaxime should be stopped.
Okay, I think, Venu, would you agree that we probably may have to move to
Yes, sir.
Sangeetha now?
Thank you very much, Ajit sir, for that wonderful talk. And I think there will be a few questions which I think we'll carry over and merge the two sessions. I am sure PAILY sir and Dr. Betsy will, take over the other topics that have appeared in this chat box. So I think we'll move to the next session as we transition. Everybody, all of us in Kfog know PAILY sir. We know Dr. Betsy, who is principal of Amala Medical College. We know, of course, our own SANGEETha madam, who is from Trivandrum. But I think we should have a small introduction for ARAVIND sir. Thank you, sir, very much for joining. ARAVIND sir is the head of Department Infectious Disease Trivandrum. He is the go-to person for everything related to COVID. I am told that regarding the guidelines drafting or any doubts or anything regarding COVID, I think ARAVIND sir is a go-to person. Our also go-to person, because every COVID meeting we have held, sir has graciously agreed to be present here. Thank you very much and welcome, sir. And I will also introduce Dr. JAICOB VARGHESE. JAICOB sir, our other go-to person of Kfog from Rajagiri Hospital. He is the head of department, senior consultant in critical care. Welcome, sir. And JAICOB sir, ARAVIND sir, and SANGEETha madam are our experts. I hand over the session to PAILY sir and Dr. Betsy for the FAQ, and please do make it an interactive. And we should see that all questions in the chat box answered. To the audience, I request all of you to pour in your questions and make full use of this session. Thank you.
Venu, I thought that we may probably have Sangeetha's presentation next and then take.
I don't have a presentation.
Would you like to make any comments or present, even though not as a slide presentation?
Yeah, but just some things that which were already discussed. I think there should be a triaging of these patients once they are admitted. And I think very important, which some of us tend to ignore, is the fact the vaccination history must be taken. So is she vaccinated? Is she not vaccinated? Because that will at least tell us, could she become, at least in our minds, could she become more serious? Is she likely to remain status quo? Then, as we did for the alpha and the delta variant history, B1, B2 categorization, and we tend to forget the guidelines sometimes, and the cough really needs to be treated with budesonide once it becomes, it's a persistent cough. Actually, the cough that we're seeing now is quite a racky cough. It comes from deep down and it's so viral, it doesn't have phlegm, but it makes a loud noise. And I think 3 to 4 days, she's not improving. We give them budesonide, 800 micrograms twice a day. And I think in the initial stage itself, we need to know, does she require, I'm sure it will come up. Everybody will ask whether, we are from smaller centers. AJITH is scaring us by telling us that we're going to hit 40,000, 50,000. We are already there. We probably will be more. So it's important for us to kind of figure out how many beds, what is our volume, where we need to put these patients. And very importantly, that there should be a clear, each district should have their own guidelines for who tackles what. Because small cases should not just go with COVID positive running all around the countryside for an admission. And I think basically the smaller centers will shy away from admission because they will say they don't have facilities to do procalcitonin, or they don't have... So I think on a basic minimum, yes, everybody will be able to do a hemoglobin PCV, TCDC, an RFT and an LFT. Then yes, a CRP and a D-dimer. Now I think all our facilities have this with us. Once they become worse, they need to be referred. And reference is, cough is not a criterion for reference because most of the patients have a cough. So if the cough is associated with desaturation or tachypnea, yes, then she needs to be started on steroids, probably remdesivir, we need to think. And assessment for risk, you need to hit early and hit fast if you have problems. So you need to categorize them early. I think, and this vaccination history, we may be seeing the tail end. Arvind had said something about we are seeing the tail end of Delta. I think each case sheet, each OP ticket, I think the days of have you had contact with the positive should go. It should be, are you vaccinated or not? I think that's a very important thing.
Thank you. Before we take up the question answer and go on to the discussion part, may I request Aravind, over and above what we discussed today, would you like to give any comments or overview on the present situation and your expectation of how we are going to, what we are going to face in the next 1 or 2 weeks?
Good evening, respected PAILY sir, Vijay madam, sir, teacher Sangeetha madam, Dr. Venu, and all members of Kfog. I'd like to thank for this opportunity. I think during the last meeting, I did say that we are seeing the tail of Delta, and for the next 1 or 2 weeks, we'll be seeing co-circulation of Delta and Omicron. I would like to take back my words, because so recently the spike protein sequencing has been done in Calicut Medical College, and out of the around say 110 samples or something, only 6 were Delta, the rest were Omicron. So that means that the tail is gone. So probably what we are seeing in the state is just Omicron and maybe a handful of Delta cases. So that has got some therapeutic implications for us with regard to the monoclonal antibody cocktail. This actually not means no against Omicron. This monoclonal antibody cocktail is not going to work. Does not have any neutralizing activity at all. The next aspect is that we did revise our monoclonal antibody cocktail guidelines. In that, we did put this pregnancy also on a compassionate ground, saying that those patients with uncontrolled GDM, some morbid obesity, ALFLB, preeclampsia, etc., might merit from monoclonal antibodies if we look for SGTF, that is S gene target failure. This is the second part of the bad news, because even if we do have access to this S gene monitoring props, so what the sequencing data says is that in Kerala also, of the sublineages of Omicron, it is BA2, which is the predominant one. Is that it's just like Delta, the S gene will be detected. So we cannot use the SGTF as a marker for diagnosing Omicron in Kerala to a large extent. And regarding the Tata Omishwar kit, they cannot scale up production, so we may not get it in near future. So for all practical purposes, maybe in a week or so, monoclonal antibodies may not have any role in the management of high-risk pregnant ladies in the state. So second aspect is like Ajit sir said, suppose we are having a GDM patient who is unvaccinated. So from the data which was shared from Kottayam Idukki, etc., during the last meeting, so only around 50% of our pregnant ladies have received both doses of vaccine. And first dose also, the take-up was there only in around say 72%, something like that. So means that there are a lot of unvaccinated pregnant ladies out there. And suppose a GDM with a morbid obesity is coming to you, third trimester of pregnancy, and our go-to drug used to be monoclonal antibody. We know it's useless. In such situations, probably we need to go with the early dose of this remdesivir from evidence from the pine tree trial. For the 3 days, we need to give remdesivir. That may be the only option left for us in the highest risk group category. Regarding anticoagulation, so we need to actually handpick patients who might benefit from anticoagulation. So we really don't know whether the thrombotic complications are less. Only some data says that compared to Delta, it is lesser. So we can handpick patients with multiple risk factors to continue anticoagulation, etc. As Sangeetha madam rightly said, rather than the severity of Omicron, it is going to be an administrative issue. Hospitals are going to be surged with the pregnant ladies. So if you don't establish very good referral systems in the district, probably your tertiary centers are going to be crowded with patients, and even those patients who require tertiary care center might find it difficult. So it's basically about allocation of patients to the right hospital. So I think Trivandrum has done that to an extent with the help of the district administration. All the districts would have done that. So that is the way in which we should be dealing with is Omicron. That's all, sir.
Thank you, Aravind. And I will ask JAICOB, would you like to make any comments over and above what Aravind already told us? JAICOB Varghese.
Okay. Yes, sir. Good evening, everybody. I think it's an overwhelming response to see 300 people joining in a holiday. I think thank you, PAILY sir, thank you, Ajit sir, Dr. Venu, all the Kfog team, because you have always stood apart in your academics, and you always move ahead of time. Now, I think Dr. Aravind has clearly mentioned about one important question I think all of us was about to ask is about monoclonal antibodies in this current variant, and with the Omicron crossing over Delta, and even though BA2 is a bit concerned, I think that part question is answered very well. However, from an intensive care perspective, we all worried about patients getting sick. However, let me put my limited experience over the past 2-3 weeks into place. ICU has been running full with patients. That's not come down. However, what change in trend I am seeing is that the primary disease what the patient has got. I'm talking about non-pregnant patients who coming to the intensive care unit with COVID positive. We are not sure about whether it is Omicron or Delta because we don't sequence. However, the lung involvement per se is very, very less. Even though we do a early CT to pick up things, the involvement of lung is not like the score what you see 20 plus, 15 plus TT severity index. It is very, very minimal, less than 8, which is normally happens in any COVID patient. We don't do a CT to confirm that. But the primary disease what the patient has got, the COPDs, the congestive cardiac failure, the renal failure, that is getting worse and making the patient sick rather than a pneumonia and ARDS. This is a trend what you are seeing for the past 2 weeks, which could be reassuring in the fact that Omicron does not cause direct to the lungs. It may cause predominant upper respiratory, and any viral infections can trigger the underlying disease. That is where the patient gets into ICU. I have a couple of patients who my own relatives who are oncology patients, and I treated them for Delta variant. They were in the ICU for one was on ventilator, survived and went back home. They were also tested positive, but touched for 7 days, 10 days. They are now asymptomatic without much of a issue. So that is a clear indication that the Omicron, we may be, don't worry much about Omicron in causing ARDS or pneumonias. The primary disease is something which you have to worry about. Number one point. Second thing, I think, Dr. Sangeetha has clearly told that that's something which is very important. Reassure the patients, especially the pregnant patients, saying that, explaining about them probably, and maybe one visit in person to a local, to the nearby centers, nearby health centers, so that, the feel and touch of a doctor make them feel happy and secure that they are okay. We have time, yes, there are small percentage can get into complication. However, we have inflammatory markers which can give that trend. CRP, a simple inflammatory markers which definitely give you a trend. And we don't need to do a CRP right from the day one. If the patient is febrile on day 4 or day 5, repeat or recheck that, reevaluate their patient and do an inflammatory markers. If that is high, that is a group which we needs to be attended. So reassurance and limiting them to the primary or secondary health centers, avoiding them coming to the tertiary center so that the crowd is avoided, so that the system is not challenged, is something which is very important. Moreover, if you ask me, if the Omicron getting into complication, the drugs available right now to treat, monoclonal antibody may not work for him. The two drugs which has been approved outside, the Paxlovid and the monoclonal antibody sotomimab, is not available in India. Molnupiravir is not recommended in pregnancy. We have only IV remdesivir. That too, the short course which Dr. Aravind mentioned after the Pine Tree trial is something which can be initiated on day 5 also, because it's still the viral phase is active. So we don't need to be worried about if the patient is asymptomatic or mildly symptomatic, which with sore throat or symptoms, to rush to the hospital. Maybe a teleconsultation or a personal visit and reassuring them will help us to come down on the panic reactions and avoid crowding the main centers. Admit if there is any obstetric indications. With regards to LMWH, there's a lot of discussions. I think, what I feel is that D-dimer is one, but not only criteria to continue or to initiate. If the patient is hypoxic, definitely they need LMWH. And I would like to add one thing is that, most of the patients in Delta variant, what we have seen in the lungs is predominantly a pulmonary thrombosis, may not be a pulmonary thromboembolism. It's a pulmonary thrombosis which is causing all this D-dimer elevation or causing all this hypoxia, where LMWH holds a value. So if a patient was admitted in the Delta type with ARDS on ventilator, extubated, then I personally feel that the continuation of LMWH, the 10-day period is almost there, or when they weaned off the oxygen, till that time I would I would like to continue the LMWH. Subsequently, based on the each patient's risk, case-to-case basis, take the next step. And the last point about the steroids, very clear indication, somebody who is requiring oxygen definitely needs steroids. In the guidelines published by the Kerala state, it is very clear that you can't wait maybe to evaluate every patient. That is why the 6-minute walk test, if there is a hypoxia developing, start steroids at the right time may help us in saving patients. However, in the Omicron type, I don't think that hypoxia part may not be there as what we see in Delta. Budicort nebulization, Dr. Sangeetha mentioned for the severe upper respiratory symptoms and the cough. Is something which is important. However, one caveat is that make sure that your patients wash their mouth after the Budicort because of the increased risk of oral candidiasis. Having said that, the last point is that we might have to wait for 2 weeks. Maybe we have to redefine certain things what you have discussed right now, because the change in trend may be evident at that time. The VA2 variant, what Dr. ARAVIND is mentioning, is something which is causing a concern. Why I'm saying is that having had a discussion yesterday in my IC colleagues from Telangana, we're having a meeting. In that, the trend what they saw is what I have mentioned. Previously, when the initial period of December end and January, they are seeing most of the cases admitting in the ICU are for the primary disease getting worse, not for a lung injury. However, the last week, the week which we are discussing right now, last week and this week, they are seeing an slightly increasing incidence of lung pneumonia and ARDS. I'm not sure about whether this is the same Omicron variant or getting into an ARDS or some other variant is causing. That is why I said probably 2 to 3 weeks later we may have to be review the situation and then see the ICU admissions trends are changing and is there a lung involvement is getting more and more. As of now, it is more of an upper respiratory. Reassure and make sure that you get the basics correct and do not overdo testing, do not overdo treatment in the beginning, because this is something which goes off like a flu. Thank you, sir. That's what my comment.
Thank you, JAICOB. Before you leave, if I may just ask both you as well as ARAVIND, both of you said that the lower lung involvement is less and then cocktail may not be effective or needed. But in case now you get a patient severe and with lung involvement, would you think of giving cocktail? Because, assuming that it could be even Delta variant?
Sir, actually, which the right time at which the cocktail is likely to work is before actually the lung injury sets in. So once the lung injury sets in, actually we need to look at the other drugs. Like we need to start remdesivir, we need to start steroids as per the protocol, as well as the low molecular weight heparin. So these are the 3 drugs in hypoxic, which are likely to alter the course of the disease. And suppose the oxygen requirement is not coming down, the CRP levels are very much elevated, more than 75, then we need to think about tocilizumab also. I don't think that in the current juncture, monoclonal antibodies hold any value in the current context of the pandemic in Kerala. And I would like to add one thing to what Dr. JAICOB said. Now, BA2, there is not much known about BA2 as of now. One thing we know for sure is that it is having more transmissibility advantage than BA1. So actually, it's very surprising how this SARS-CoV-2, this Omicron is behaving, because now Delta, the CDC said that it is just like a chicken box, and we all thought that we won't be having more transmissible virus. Now we are having Omicron, which is around, say, 5 times more transmissible than Delta, and is having more reinfection potential, around 4 to 5 times than Delta. And the BA2 sublineage is having more transmission advantage than BA1. And then I don't know, the CDC said that Omicron BA1 is behaving like measles. Now I don't know what they are going to say about BA2. So it's surprising, as said. So regarding the severity aspect now, the thing is that in Denmark, Norway, etc., the BA2 has surpassed BA1 in a couple of weeks. So that we will have real concrete data on the ICU admission trend, etc. Just like what he said about Telangana, we'll have hardcore data from Europe as well. So if it is causing more virulent, if it is more virulent than BA1, we are in for some trouble, sir.
Thank you, Arvind. Before I pass on to Betsy to take up the chat box as well as question answer, I may request Sangeetha to comment on one thing which actually Ajit also touched upon. That's about the delivery part, mode of delivery. And see, we are now facing the problem not only about the COVID in the patients, but about the staff. So with the acute shortage of staff, is there any change in the way you approach pregnancy, late pregnancy inductions, delivery, cesarean section, low threshold for cesarean? and all that?
Yeah, sir, as far as possible, we stick to the routine obstetric guidelines, except when they start approaching 38, 39 weeks. Now, suppose she has had COVID in the past, has recovered and then comes, we think of induction at 39 weeks because there is an increase in the stillbirths. There is an increased incidence of fetal distress and meconiums in labor. Therefore, 39 weeks is good enough for us. But all the other medical disorders like hypertension, diabetes follow the routine, 37 weeks for hypertension, 38 weeks for insulin. We don't definitely allow them to cross 40 weeks. Somewhere between 39 and 40, we deliver them based on obstetrical indications. Our cesarean section rates, which were something to the tune of about 58 to 60% with the Delta and possibly even the Alpha, has now come down. Very many of them are delivering. We follow the mean Bishop score. If they're unfavorable, we wait. We give them the Foley catheter, give them prostaglandins, and 3 days we deliver them. But in the acute phase of illness, preferably I feel they need to get a little better in order to withstand labor or cesarean section. So once their fever is down and their cough is better, we take them up. But we don't cross 40 weeks. Somewhere between 39 and 40, we deliver these patients.
Sangeeta, the problem is how to give them the staff support, because there is staff shortage on one side. And if you start inducing at 39, even at 39 weeks, you means the time of care, acute care required is more. So we find a big difficulty in that. So we try to push off to the last minute possible the decision on induction in these patients. And this concern about the stillbirth that you mentioned and not allowing them to go beyond 40 weeks, has it been proven in our setup?
Ours, there are, and everybody will have their experience with an unexplained stillbirth, not amounting to statistical significance, but the RCOG talks about a twofold increase in stillbirths. So,
ACOG also. ACOG also. Yeah.
Yes. So, considering all this, in the face of an acute infection, she has come out of it. What we do is by 39, we deliver by about 39 plus 5. Yes, it is labor intensive because we have a schedule, we have a nodal officer, so we submit all our induction to her. So when we decide, we submit it and she decides not more than 2 to 3 per day so that it is leavened off. Like, see, for example, I have a diabetic, she's crossed 38 weeks. I'm waiting, but 38 plus 2, I have a slot, I will start induction. The Foley takes some time, so we have, it's not, all of them don't rush in at the same time. Prostaglandins, the use is less, so we don't have that much of hyperstimulation. They go along slowly, they are monitored. Yes, we have a problem with the NST machines, we don't have enough. Very many of them are not working now, we still have to get our new ones. All these are issues. But I don't know whether we could wait beyond 40. I would be worried about waiting beyond. I'm a person who likes to wait and wait, but in the face of COVID, I think beyond 40, I would not. But somewhere between 39 and 40.
Yeah, we understand, Reshma. I mean, we understand. Can I just take up one question from the chat box and then pass on to Betsy? Dr. Reshma was saying that as per the latest guidelines from ICMR, no need of testing for admission and procedure. Is there anything like that? For admission and testing, you don't need to, for operations, you don't need to test?
Yes, only symptomatic patients. If anybody is getting admitted and is symptomatic, they need testing, but routine testing is not required.
For elective surgery and all that, do you test now?
Elective surgery, they've said it's not required.
Oh, is it
but
so?
We still test. Let's be frank, we still test.
ARAVIND, do you think that is, I mean, I did not know that.
Actually, since ICMR came out with the purposive testing guidelines, but then there is they have mentioned one thing, it is the discretion of the treating doctor. So, I believe that for all the obstetrics and obstetric centers, they should be tested because now we are dealing with a very high risk population. So, should be tested. So, discretion means that no, we can decide to test that. But then they have clearly said that prior to a procedure, etc., you should not be looking for a testing, etc. ICMR has clearly said that actually the spirit of the guideline is that just because the test is positive, some procedure, etc., should not be deferred. That does not really apply to obstetrics, because now whatever has to be done has to be done. Really applies to the other surgical specialties where, you know, once you get a test positivity, the procedures, etc., might get deferred. So that is actually the context of the guideline. It does not apply to obstetrics per se.
Yeah, the other aspect that, as Dr. Kamappa has put out, see, the question is, in the obstetric management, for example, labor and all that, the number of people involved in the care and the risk of that, if there's a carrier or an infected person who we do not know, is so much more. It's just like taking somebody to theater or even worse. So that is the concern that most of the obstetricians have in this policy. If you say no need of testing, at least an antigen testing, as we discussed the other day, I think should be the norm for these patients. Can I pass on to Betsy? Please take up. And
yes, thank you so much, sir. Other than what we already discussed about the admission policies, Sangeetha madam, there are a lot of questions about vaccination. The third dose in pregnant women, do we really recommend that?
As of now, the government has not given us any clear guidelines that we should be giving the third dose. The women are not being given the third dose as of now. But personally, I think if they follow if they have fit into the category for the vaccination, if we've given the first and the second dose, I see no harm in giving the third. But this, as of now, we are not vaccinated. The third dose is not being given.
No,
to
but
pregnant.
Sangeetha, they haven't said not to give also. And it is 9 months after the second dose, the government gives and doesn't make any exemption for the pregnancy. I would personally feel that we should.
We should. But we have been given guidelines that no, Trivandrum district is not giving any way for pregnancy, not for anything else. The government, the district administration hasn't given us the green flag. Is that true, Arvind? We have not been giving.
As of now, this applies to a pregnant healthcare worker. So in a pregnant healthcare worker, you know, definitely, so if they fall into this 9 months criteria, we can give. Other than that, no, as Sir said that from a scientific perspective, they need to take the booster dose if they are allowed to. If they pass the 9 months following the second dose, etc., they need to take the booster dose. But
The
then,
next
no,
question.
whether pregnant ladies, no, the thing is in the COVID portal, there are the specific criteria there. No, if you want to enter and all, as of now, it is for the elderly with risk factors and all, then healthcare workers and frontline workers.
Right.
I'm not sure that if a pregnant lady, if you're applying like that, I don't think they will be allotted the slot as of now.
And they're getting special consent from pregnant healthcare workers also when they go for the third dose.
Yes.
Madam, one more thing. Actually, our good clinical practice recommendations, what we put forth a few months back, should we be changing a few points like when to admit? That time we said about 34 weeks, 36 weeks, it's better that we admit all the pregnant women. Should we be not changing that now?
I think now Omicron is not such a worry. As long as they have a pulse oximeter at home, they're able to report back to us as a telephonic consultation. I don't think even third trimester requires admission until they are close to, let's say, 38, 39 weeks when you need to get them in. Probably even then, in 5 days, 7 days, they're negative and they come to the routine pool. So if we can not overburden the COVID pool and take them in the non-COVID pool, it would be better. But I think admissions of any nature, we should not, because in our kind of a setup, you can't expect them to sleep with a mask. In the ward, 1 positive, and then there are 4, 5 who, any elective list you post, 50% are positive. So I don't think we should bring them in at all unless they have some issues. They are
we should emphasize that point, especially because of the mild nature of the disease and the high contagious nature of the disease. Admission just because they are 34, 36 weeks should not be promoted.
That will answer one query also. Just for the sake of low molecular weight heparin, we don't have to admit. One query had come.
Actually, low molecular weight heparin should follow you score the patient, and if she's admitted, you think of heparin. If she's not admitted, just because she's third trimester, she doesn't require heparin.
Dr. Aravind, what's the role of D-dimer in deciding whether we have to give low molecular weight heparin or not?
Actually, even in adults now, we don't look at D-dimer to decide on whether the patient requires anticoagulation. The one factor which is indication for giving anticoagulation, is hypoxia. So all the patients with hypoxia should be given anticoagulation. That is what we follow in adults. In pregnancy, why we were a bit liberal with this anticoagulation was that pregnancy per se is a prothrombotic condition. But then at this juncture, we cannot just have patients admitted for anticoagulation. And the real benefit in such group, the asymptomatic pregnant ladies, etc., we really don't know whether it will benefit at all. So we need to go by the scoring system, like RCOG, Green Top guidelines, etc. We can apply. We can take this COVID-19 as one factor, one risk factor. Let us look at other risk factors also. Look at the stage of the pregnancy and decide whether the patient requires anticoagulation. In hospitalized patients, just because they are hospitalized, we are giving prophylactic dose anticoagulation. That is actually the standard of care in the West. So admitted patients we are giving, but for giving prophylactic anticoagulation, we should not admit a patient.
Can I say something? When we taught before the COVID era, we always said D-dimer was not at all significant in pregnancy. We never used it to diagnose DIC or anything. But when RCOG came up with these cutoff values, we are following it to the T. At the same time, now with Omicron, I have very few, in the sense, the ones with high D-dimers are a handful. We have not started them on heparin. There are D-dimers of 7 who are fairly normal, with absolutely no problems. We started, one was 39 weeks. We decided we're going to induce, but I don't think in the face of I have no data to tell you offhand that this is the way to go, but I don't think D-dimer is going to help at all with Omicron.
Can I add the comment here?
Yeah, sure.
Yes, sir.
I think that's a good discussion. I think we have, let me put some examples. See, I just put one experience 2 days back, probably. 20,000 was a D-dimer, referred to as probably pulmonary embolism. This is something which quite often gets in tertiary centers like us. But let me put you CTPA, anybody referred, we need to do it. So CT pulmonary angiogram was done, which rolled out a pulmonary embolism. So I'd like to put one important point here. Oxygenation issues, hypoxia is definitely an indicator for starting LMWH. Why I'm saying hypoxia is that even though there is no pulmonary embolism, pulmonary thromboembolism in the main pulmonary artery or segmental pulmonary artery, one of the reasons for hypoxia is thrombosis in the smaller vessels in the lung parenchyma because of the ARDS or lung inflammation because of the COVID. That is why the D-dimer could be going up without a pulmonary embolism. That is for patients with hypoxia. Now, other patients who doesn't have hypoxia, who is otherwise asymptomatic, D-dimer borderline going up. Let us put an example of a small peripheral line induced, a cannula-induced thrombus in the hand. That itself can increase your D-dimer. A small hematoma, which whatever reasons it is there, a small cut injury, that all these things can increase your D-dimer because of thrombotic event. So D-dimer is not something which should be a trigger or should be a criteria to start LMWH. Hypoxia, yes. Drop in saturation, yes, that is the criteria to go for it. Otherwise, admitted patients with high risk, obesity, all these things definitely should go for a LMWH. This should be a reasonably, reasonable protocol to follow in any centers.
JAICOB, what we were discussing D-dimer, especially in pregnancy, as such, that D-dimer values will be physiologically more. That is what I think Sangeetha wanted to bring in.
Yes, sir. It's again, same like the cartoon, pregnancy itself, D-dimer can go up. So don't go by that only. Take it clinically and do it.
And there were 2 queries about aspirin also. One is when to stop aspirin, when to restart aspirin once we have already stopped because of COVID infection. And second one is whether we can continue aspirin in the postpartum period instead of low molecular weight heparin. I think first one, Dr. Sangeetha can take up. When can we restart aspirin if we stop for COVID positivity?
See, once she becomes, now as per the guidelines, after 7 days, we are not testing. We consider them as negative, unless she is a category C patient, which is very rare. So once the 7 days is over, the 7-day time when she is COVID positive, let her not take her aspirin. But if she's an APLA or, somebody with a very bad obstetric history, maybe she needs to come and we need to look at a platelet count. I think a platelet count, if she comes to the hospital, must be done. And you restart it. Though there are no guidelines, I would restart it once she's out of her COVID. When she comes to the general side or after 7 days, you restart her aspirin. But I really don't think we should be giving low dose aspirin for thromboprophylaxis because it's an antiplatelet. It really
Yes.
will, it's not an anticoagulant. So it will not.
Okay. For the postpartum patient, there's no role for aspirin to send her home with aspirin. And now there are a lot of people who think this isolation and quarantine, already I think in the government side for high risk contacts, there's no need for quarantine. The rule has come again. I think Dr. Muralidharan, somebody has put up in the chat box whether we really, is it necessary to have all this isolation and quarantine because there are so many positives outside. I think Dr. Aravind can take it up.
Actually, from the government side, initially the Trivandrum Medical College, now we took away the the high risk contact isolation for all the healthcare workers, and following that, the Chief Minister announced that for all the government employees, this high risk quarantine is not there. They won't be eligible for the special COVID leave. So for all practical purposes, the high risk isolation means if you want to be in isolation, you can, but no, the special COVID leave is not there. So that really sends a message that we are not really into isolating the high risk individuals. Now we need to learn to live with COVID-19 because DPR is 50%, etc. Just signifies that if you test everyone in the hospital, all hospitals are likely to be COVID hospitals only. So one category know that they are COVID positive, other category we really don't know their status. That is actually the reality with majority of the hospitals. The second aspect is that the Omicron, the way in which it spreads, around 4 to 5 times more transmissible than Delta, it really will result in the huge clusters. That is what we are seeing in the household clusters are there, institutional clusters are there. So really, I don't think that we will be able to prevent the spread of Omicron. The good thing is that, and there is another aspect of this, why the government is not being very stringent with Omicron like what we used to be with Delta or the previous variants. There is a bit of a difference between the Delta, the wave as well as Omicron wave. At that time, the vaccination process had just started. We were a vulnerable population. But as of now, out of the eligible population, so first dose has been taken by, I don't believe it is 100% is the list given by the center. We have crossed that list. So we can say around 99% have taken the first dose, and second dose has been delivered to around 85% of the population. So we can't do really more than this. So as the host party is concerned, so majority of us are really protected. The concern should be with the elderly who didn't have developed these neutralizing antibodies, or the immunocompromised, the CKD on dialysis, etc., for whom the vaccination or the hybrid immunity wouldn't have kicked in, and to an extent, pregnant ladies as well, because their vaccination coverage is also not very high. So from the host side, so we are really prepared. And now from the agent side, we look at the virulence of the Omicron compared to that of Delta. So the pathogenicity is less. Now it is the replication in the bronchus is actually around 60 times faster than that of Delta, but the replication in the alveoli is less, the syncytial formation, etc., is less. So we are actually on advantage. The problem is actually the speed with which transmits. So the chance of severity is concerned because of vaccination is good. So if we don't if we go for stricter restrictions now, the psychosocial stress is going to be huge on the population. Economic concerns are there. One thing is that our routine immunization did take a huge hit because over the last 2 years, all our healthcare workers were behind this COVID-19 because of our plateauing the peak strategy. That was needed because our population was not vaccinated. But as of now, we don't require this plateauing the peak concept. As far as the hospitals are concerned, the ICUs are not full. At least in the government sector, the ICUs are not full. They're keeping a tab on the hospitalization, ICU occupancy, etc. And that is why the districts are divided into 3 categories. And in the category C, the restrictions are going to be more than that. So as Muralidharan sir said, we are into a phase where we are trying to restart all our normal activities. Even the schools, they are closed following one cluster formation. That is why the government came up with the cluster management, saying that, so you cannot, cluster means more than 2 cases. Now we redefined the cluster, said that if there are 5 or more large clusters only, you can close the hospitals. And as Ajit sir did say, so by April 1st and on, we probably will see that total means the cases will be very less. Then we can restart all our non-COVID activities in full swing. What I mean is our vaccination, etc., can go on. So if you look at the Indra Dhanush report, Indra Dhanush means our catch-up vaccination program. Last year, around 9 districts from Kerala were included in the list. So getting into a list means that now we have fallen back on our catch-up immunization program. All this happened because all of us, all the healthcare workers were running behind COVID. That was needed because if we hadn't adopted that strategy, Delta would have instilled a lot more people than it actually did in this state. But as of now, this is actually a well thought of gamble. So we are all been sort of vaccinated. So it is time to, we should allow this COVID, this Omicron to peak if our hospital infrastructure is adequate. That is what I believe. So we can't expect any strict restrictions.
Dr. Aravind, unlike Delta, do you think like Omicron remains on the inanimate surface for a longer time and it remains in the atmosphere for a longer time? Is it the reason for rapid spread?
Actually, the reason for the rapid spread is not because it is hanging in the air for a longer period of time. Delta also used to do that. It was actually Delta that the WHO said that it is an airborne transmission. So actually from the beginning in the Kerala was using N95 mask where the WHO etc. were saying triple layer mask was enough. So probably one of the reasons why the healthcare worker mortality in Kerala is probably the lowest in the world is because right from the beginning, that is from April 2020 onwards, if you look at our guidelines, we had always insisted on N95 mask. Definitely it is better than a triple layer mask. So whether it is hangs on the inanimate surface for longer periods of time, data is not clear. But why it is infecting more is because of the mutations in the spike protein as well as the receptor binding domain. There are 17 mutations, which actually makes it easier for the receptor binding domain to attach to the ACE2 receptor compared to Delta. And that is the reason for increased transmissibility as well as immune evasion, the mutations in RBD. And there are mutations in BA2 are different from that of BA1. The reason why it is more transmissible than BA1.
And one more radical question was like whether we can give up all our PP kit and just use N95 mask for a cesarean and normal delivery with COVID positivity.
Actually, means what you could take for H1N1. So that is N95 mask and the face shield is actually enough. So around 7 months back itself, Kerala government did come out with a guideline saying that the guidelines from WHO as well as CDC says that you require only a surgical gown and N95 mask and face shield if needed, face shield or goggles. Okay, there is no need for a foot cover, no need for a headgear, etc. Only in select circumstances where aerosol generating procedures are needed, if they are insisting, you can use a PP. So I don't use PP, etc. But then I ensure that we are having a very good quality N95 mask. Putting on a PP and going on with a N95 mask, which is a very loose fitting, means that you will definitely get the disease. And going on with a very good N95 mask for say 12 hours and then taking it off to take tea does not serve any purpose. So what I would like to say is that invest in a very good quality N95 mask and then be in situations where the physical distancing is maintained, be in situations where there is good ventilation. Always practice the 3C. 3C means all of us can get infected from the community as well. It's very, very important, not only from the hospital. So 3C means we should try to avoid closed spaces. That is, if possible, try to avoid being in a lift, take the stairs. The second is avoid congested places like, mall or in a market, etc. You should not be going to such places, at least for the next 1 or 2 months. Third is the close contact things. Even if you're having an N95 mask, if you're going very close to the patient and talking, probably you can get infection. So you need to maintain at least a 1.5 to 2 meter distance between yourself and another person. So the 3Cs is also very important. And along with that, the ventilation to an extent in the government hospitals, etc., especially in SAT and all, if you talk about ventilation, it will be like sacrilege like scenario, but still we can follow the other things like putting on a very good N95 mask and trying not to share our meals together, etc. That should be enough.
And do you really believe that Omicron will phase out Delta? And Shekharan sir is asking whether antibodies are produced against Delta by Omicron infection.
That's the best thing about Omicron is that it will replace Delta, no doubt about that. That is what the data from South Africa showed. That is in actually around 3 weeks, the Delta was replaced. South Africa was having a Delta wave, and then the Omicron actually was sort of a blessing in disguise. That is, it wiped out the Delta, replaced Delta in 3 weeks. And the most interesting aspect is that even though the antibodies against Delta is not protecting against Omicron, the antibodies against Omicron are protective against Delta. So if you're having an Omicron infection, you're not likely to get Delta infection in future because of neutralizing activity. And today, I think ICMR also came out with a statement in vitro. They also did the study and said that the neutralizing antibody produced against Omicron has got cross protection against Delta. That is actually a very, very good news for us.
It's better than a vaccine.
I won't say that. Because still Omicron kills, because South Africa, even though they said that now everything was mild, after 1 month analysis of all-cause mortality, there was 50,000 excess deaths. So I won't say that Omicron can be equated with a vaccine.
Okay, coming to the therapeutic part, is steroids, the role of steroids is the same as it was in Delta, like same indications and same usage for steroids?
Definitely, madam. Thing is that we should not be misusing steroids. There has to be, as Dr. JAICOB always mentioned, there has to be an element of hypoxia. So that hypoxia element could be what is the perceived hypoxia, that is a resting desaturation that we are not going to miss. The second aspect is that the exertional desaturation means that the patient is having an interstitial involvement. That is the importance of 6-minute walk test. In pregnancy, especially in the third trimester and all, probably the 6-minute walk test may not be possible. So in that situation, if you're taking an X-ray and you're seeing the perihilar infiltrates, and if you feel that if you're making this patient walk, then there is likely to be a desaturation, patient is having a dry cough and all, then we know that there is an interstitial infiltration going on. Probably it can be a marker of hypoxia in the coming days. So there has to be an element of infiltration into the interstitium or alveolar infiltration to start with steroids at the right dose. As sir did say, steroids are lifesavers. They are given to the right patient at the right time, at the right dose for the right duration. You should not misuse it.
Thank you so much. Dr. JAICOB, you're mentioning about the thrombotic events. Like someone wants to know whether the risk of thrombotic events is high after vaccination. Do we have any data from our own state?
Madam, I don't have the data from the state, but yes, this particular entity called as VITT, vaccine-induced thrombocytopenia thrombosis, is something which, if you want to ask my experience, there are 2 cases which we have seen, which is the Covishield was a vaccine implicated in that, but we are not sure about that. But probably infection per se can cause a thrombotic events high. However, it is mentioned in the literature that VITT is not a very common. I don't think a lot of cases are reported. Otherwise, we would have known about it. And I am not sure about, but Dr. ARAVIND can tell the state has got any data on that, because data is not available for us right now. Yes, there are indications of VITT, but it's not much. We can definitely treat with and avoid it. So that doesn't hinder the vaccination strategy for anybody.
I will add on to that. Thrombosis or thrombocytopenia syndrome with the AstraZeneca vaccine is a reality. And, the data says that it is actually following the first dose of the Covishield that you are likely to develop this TTS. And then the incidence or prevalence, you can say, is say around 1.5 per 1 lakh vaccination. If you're asking about the state data, so I have the data till around 80,000 vaccinations were administered. We had around 2 cases of thrombocytopenia syndrome. Okay, the problem here is that at that point of time, it came in the media, and also our vaccination took a big hit. That is probably the reason why, if you look at the vaccination of the state per se and the vaccination pregnancy, the vaccination pregnancy is lagging behind because of probably those 2 cases which came into the media. The other side is that at that point of time, we had around, say, 75 deaths in pregnancy because of probable Delta virus infection. During the 2020, probably during the D614G or the initial Wuhan strain, we had only around, say, 6 to 7 deaths. And then during the Delta wave, we had around, say, 70 deaths. So we should have been able to put across to the pregnant population that, the risk with vaccination is there, but it is, say, 1.5 per 1 lakh. But the risk with COVID is that now we had around, say, 70 deaths due to COVID-19, especially in the pregnancy with GDM, etc. But the difficult question always was, will you be able to predict who is going to develop this TTS? That is going to be the difficult question to answer. It is supposed to be sort of an idiosyncratic. So the answer that comes to our mind is that the pregnancy with, say, APLA syndrome or any previous thrombophilia, etc., would be the people who are likely to develop this TTS. But unfortunately, it being an idiosyncratic event, so anyone can develop this thing. But definitely the benefits of vaccine definitely is going to be much, much more than the risk of TTS. TTS is a reality that we need to accept.
There's a query whether vaccination during an asymptomatic infection. Yes, sir. PAILY, sir.
No. taking on to what Aravind said, in the beginning of our vaccination strategy, we had those 2 cases. And unfortunately, we were involved in both. But since then, I think there was 1 more case in some other part of the state. But after that, have we had any case? I don't think we had, to our knowledge, any case near about here. And especially in pregnancy deaths, we didn't have. Did you have any other report?
No, sir. Also, only unfortunately, those 2 cases happened towards the beginning of the vaccination drive.
That's right.
Yeah, actually, that is what actually happened. So actually, the UK data is 1.5 per 1 lakh is applicable to our state as well. So even Germany says that they have around 6.4 per 1 lakh, but I don't think that is true with our state. It's around say 1.5 to 2 per 1 lakh population, but we don't have an option, sir. So we don't have
What I wanted to know was, Aravind, I mean, these 2 cases we knew about, and have you had any other reported cases in the state?
I think no, sir. I know, no, sir. But then there is another aspect to this. The state AEFI committee has not been meeting for quite some time because of this strike and all. This is also a concern. But as Sarah said, that the pregnancy-related deaths definitely we will be knowing. It's a sensitive issue.
So I just add on comment. The first dose was the main things. After second dose, I don't think anything is reported even in the Western data also.
True.
What I meant, JAICOB, was that those 2 cases in the early stage of vaccination, we were concerned and it really did hit.
Yes.
But
yes,
after that, the vaccination drive picked up. And
Yes.
as you said, now our coverage is so good. And in that drive, we didn't have any such reports. So that is quite
Yes, sir.
reassuring.
Yes, sir.
True, sir. That is true, sir. After the initial, the 2 things, then it went off smoothly.
There's a
Betsy,
query
please carry
whether,
on. Yeah.
yes, sir, sorry. Paili,
Carry
sir,
on, carry on. Yes.
Sir, actually, we were trying to collect some data on VITT. Sir was actually like passing on some Google form. Could you get any data back, sir? VITT?
No, actually, no. And we don't think, I mean, even anecdotes we haven't heard about. So I think that is quite reassuring.
Okay, sir. And 1 query is regarding vaccination during asymptomatic infection. Does it really cause increased risk of thrombotic events?
And that actually, madam, we don't know. There's something which the question is being asked. Everyone who is taking the booster dose, the healthcare workers are turning out to be positive. So what is the reason for this? Unfortunately, the timing, the rolling out of booster dose in the state or in the country was not the ideal one. So we were into the pandemic, and then we started off with this booster dose, meaning that majority of us would be asymptomatically infected because of previous immunity. We never manifested it, or we were in the incubation period. At that time, we took the booster dose, and it is just like a boost to our immune system to fight against the virus. That is why majority became infected. But whether it will lead to these thrombotic complications, I am not really sure about. One observation is that if someone says that they took the vaccine and now they are positive and now they are having high-grade fever, myalgia, etc., I make it a point, it's not with relation to pregnancy, to look at the D-dimer levels. Okay, as madam said, this is a concern to us also because the spike protein is thrombogenic, lead to endotheliitis as well. This applies only to the Covishield vaccine. And look at the D-dimer level as well as the platelet count, madam. So in some patients, the D-dimer levels are elevated, but then no one has developed thrombosis due to that. That is it. But then I am a bit more careful in patients who develop this infection with the recent history of vaccine also. A bit more careful in such groups.
Okay. Thank you, sir. Sangeetha madam, what do you think about when should be taking up elective gynec surgeries after COVID infection?
When there was a recommendation by the ICMR for the Delta variant, and that was 1.5 months. That is 6 weeks for non-elective surgeries. I am told that the ICMR has brought out a new thing for the Omicron that says 3 weeks, but I have been looking for it everywhere. I have not found any. I have not read it. But today somebody was saying, is that true, Dr. Arvind? Is there any? I looked at all the things, I could not find. But
I don't know, madam.
Now it's 1.5 months, 6 weeks.
Only that document is there, madam. American Society of Anesthesiology document is there.
Yes. That is there, and that is 1.5 months, because not just the healing and everything, but even the anesthesia concerns they have for the thrombosis. But yes, considering the fact that Omicron is so much milder, maybe they will come out with a shorter period. But as of now, nothing has come out.
But the concern for us is, Sangeetha, we have to consider need for cesarean for somebody where we cannot wait that 1.5 months and all that.
Obstetric grounds, and we are talking, elective surgeries, gynecological surgeries, things that could have waited, fibroids, all that. I don't know, as of now it is 1.5 months. Maybe they will have something that says we can do it earlier.
I think we have covered most of the questions, maybe 1 or 2 questions on inflammatory markers. Do we routinely do inflammatory markers in the 3rd trimester? Sangeetha, madam?
We do a CRP and a D-dimer, and we go by the routines. But suppose she desaturates, which was the same protocol that we followed even in the Delta times. Suppose she desaturates, she has symptoms, then we do the rest. Or if her pulse rate is more than 110, 125, we do a tropi. Suppose she desaturates, then we do the LDH and the ferritin as well. But as a routine, no. As a routine, only CRP and D-dimer if she comes to the hospital and she's admitted. But otherwise, not as, from home quarantine, they don't need to do all this.
Okay, thank you, madam. I think monoclonal antibodies was already covered. Yes, PAILY, sir, sorry.
Dr. Rakhi Anand has asked, is Covaxin to be recommended above Covishield for pregnant ladies? Any comments, ARAVIND?
I believe that Covaxin is a safer vaccine than Covishield, but the problem is that the effectiveness-wise, Covishield does score over Covaxin. Government of India has not made any distinction between Covishield or Covaxin, and whatever you can get, you need to take. When we made the recommendations at that time, the Covaxin availability was a bit of an issue, sir. So, safety-wise, Covaxin is actually better than Covishield. Effectiveness-wise, Covishield is better than Covaxin. That is the situation.
No, but again, as we discussed a little while ago, if we did not have that concern about the thrombotic thrombocytopenia with Covishield after the initial 2 cases, I think we should not make any distinction whichever is available to take, isn't it?
Definitely, sir.
And again, 2-3 questions about home isolation, whether we can send asymptomatic people home. That's what the discussion has already happened.
Definitely, yes.
And one concern everybody expressing is, I think it is coming mainly from the government hospitals, that patients being referred to the higher centers, that you also referred to, Sangeetha, and I think Beena from Kottayam has expressed, JAICOB from Manjeri had mentioned the other day. All of you I know are bothered because patients, just because they are COVID positive, are sent to the highest center possible, and recommending that they should be tackled wherever they arise, rather than sent to a higher center. You want to say anything about that? I think you already mentioned that.
I think that is extremely important. Each district should form a group of HODs of the individual hospitals and clearly outline who tackles category B1, who tackles category B2, first, second, unless it's late 3rd trimester, they don't need admissions. And the tertiary center should have. There was a time 2 days ago, Hema was very worried because we had not a single bed. We were full everywhere. And you can't make COVID patients lie on the floor. And people were being referred for no rhyme or reason. But that has sorted itself out. Yesterday, we had no referrals. I think we had only 1. Today, we have 2.
No,
but I think the dialogue is important. Between the doctors, the dialogue is important. And where to go instead of for example, one patient has come with a threatened abortion. She went to 3 hospitals and then came to us. All the 3 said, no, we take 3rd trimester. Another person said, no, we don't take COVID at all. And she's having bleeding all along the way. I think that's a sad thing.
No, Dr. JAICOB from Manjeri also was saying this problem the other day, and you also referred to the RCH officer being of great help in preventing that sort of a referral from the periphery to the higher center.
Yes.
I think a coordinated action between the DHS staff as well as the medical colleges, or periphery and the center controlled by the RCH officer or the health authorities may be the answer to the problem. Let's hope that the load on the hospitals will rapidly come down, just as Arvind was saying. There's nobody else to get infected now, so in Trivandrum and Ernakulam, probably we may not have new cases. Let us hope that will be the reality. Yes, over to Venu.
Yes, sir.
Yes, sir, one question, even in the chat box is there. A 39 weeks patient, we are planning to induce labor, low-risk patient. There is no indication, just a social induction. We do a COVID test, it comes as positive. What should be our plan? Can we proceed with the induction?
I think Sangeetha referred to this point in her presentation, saying that we would like to avoid inducing unless there is a compelling reason, electively when somebody is at the peak of the infection. If the time allows for us, we don't, we used to have, as all of you may know, an elective induction of 39 weeks policy. Now we are relaxing on that, waiting till about 40 weeks, even though all the literature says there is a doubling risk of stillbirth and all that. It is not really intrauterine death as such.
Can we send the patient home, sir? There is another question asked by Sadiq.
We do, unless they have symptoms, we do. And then bring them in closer to 40 weeks, maybe 39 plus 5, like that. Until then, if we could ride over the peak, then that's what the infectivity for others, including the staff, will be less. The other reason, of course, was that even though ours is a much smaller setup compared with what many of you face, still the staff allotment is different. We have to have a 1:1 or at least 1 nurse for 2 patients when we have a patient in the labor room. For a government medical college, it is not required. It's not only nurse who sits with them. You have the PGs and so many other categories who give care. So depending on the situation in each hospital, we have to decide. Our own policy had been to take it delayed, and if possible, we can get over the peak of the infection. We try to delay till then. We don't like to allow them to go beyond 40 weeks. And as Sangeetha mentioned, our threshold for C-section has come down very much. We cannot induce for 2 days and all that and give this sort of a care. So if the service is unfavorable, they have reached 39 weeks, maybe we'll give a folly and see how the response is. In about 12 hours, if they haven't come around very easily and smoothly, then we may take them for cesarean. And we do take a very low threshold for cesarean. That has been the big change in our practice, where we had been all along keeping a primary section rates 15 and anyway below 20 all along. But now we are relaxing on that.
The advantage is that we can decrease the crowd in the COVID pool also.
Sorry, I didn't.
The COVID side, we can reduce the crowd on the COVID side, no?
Yes. And even the non-COVID side, I think we should be very slow regarding admissions. They can let them come in labor if they have no other complications. We should not admit early. This 38 weeks, 39 weeks admission should all stop because they'll become positive.
Any patient coming to the hospital is, if you test,
Yes.
is positive.
Yes.
Hospital admission is a risk factor for COVID, isn't it?
Shall we wind up, sir?
Yeah, yes, Venu, back
Yes,
to you.
sir. So for the last word, they usually say calm before the storm. I hope we are riding the storm before the calm comes. So I think even though it was a hastily convened meeting, but I think it was really worth it. And I hope all of those who attended, they really benefited from this really interactive session. For making it so interactive, I would like to thank Ajith sir, AMBUJAM madam, PAILY sir, BETSY madam, SANGEETHA madam. And then our 2 encyclopedias, ARAVIND sir and JAICOB sir. I think your lively answers to all questions, you really deserve a big round of applause. And thank you so much for enlightening our members. I think you have been a lot reassuring also in your answers. And I think all of us will benefit. Of course, the Sun team, Hari and Dinesh, even though we hastily convened this meeting, thank you very much for helping us with this platform. Thank you so much. And also Kishore from Medcom Solutions, thank you very much. So very good evening to all of you. I think we started, it's nice to start and end on time. So till we meet again, thank you very much. Thank you.
I can probably announce the AJITH program on Sunday.
The next Kfog update for all our members is there on Sunday evening. We'll start at 4:30 p.m. sharp. I think we have got a very impressive lineup of very good speakers and good topics. Intensive care in obstetrics. Then we have lessons from CRMD. Then we have eclampsia, pre-eclampsia, hypertensive emergencies, and some very good topics and very good speakers. Dr. Pratima Mittal, PAILY sir himself is there. Dr. Jaideep Tank will speak on vaccinations and pregnancy. So all do please join us for that session also. With a flyer will be ready by tomorrow. And this meeting, of course, as always, we will put it up on our YouTube channel. I hope for those who couldn't attend today. Thank you very much. And once again, thank you.
Thank you.
Thank you.
Hari, tomorrow, please give me the recording.
Okay, sir. Okay.
യൂട്യൂബിൽ ഇടാൻ കാര്യം ഇത് പെട്ടെന്ന് തന്നെ ആവശ്യമുള്ളതല്ലേ.
അതെ,
നാളെ രാവിലെ തന്നെ
നാളെ എനിക്ക് തന്നാൽ മതി. അപ്പൊ ഞാൻ നമ്മളുടെ യൂട്യൂബ് ചാനലിന് ഇട്ടേക്കാം.
ആയിക്കോട്ടെ സാറേ.
Ajit sir, thank you very much. Hari and Dinesh also once more, and Kishore.
Thank you, Hari, Dinesh.
Thank you, sir. Thank you.
Thank you, Kishore.
Good night, sir.
Ajit sir.
Okay.